Welcome to everybody to this open online briefing. This is the second series of these briefings offered by Forest D Foundation. Today, as you've seen in our newsletter, thank you Tui for it, it's a special focus on COVID-19, which is back in the news. Today, our session will be illustrated by Maya Schmidt, who is from Live Illustration UK, who will scribe the session. Thank you, Maya, for being on this call. And we will start with an informative briefing by Dr. Nabarro for about 25 minutes before I come back to give you the floor for any question to David, to each other, sharing your own views and perspectives in this conversation. Without long ado, David, to you for this briefing, COVID-19. What's happening, please?
Thanks very much indeed. Well, I want to start by saying how lovely it is to be reconnected with people with whom we've been working together for so many months. A special shout out to every one of you, and not mentioning anybody much by name, but I did want to say how delighted I am to see the name Gregory Hartl, WHO, here. Now, Gregory works as not just as one of the communications leads within WHO, but also provides support to those of us who are working as special envoys of the Director General on COVID-19. And I think that Gregory is, at the same time as being connected here, probably listening to what's happening as Tedros and team are briefing the media. And so I see your face, but I kind of imagine that you're double or multitasking. Gregory, as and when you wish to come in, please don't hesitate. And I say that to everybody, although Florence is offering me the chance of giving a bit of a monologue at the beginning, as I see who else is here. For example, Dr. Fawzia Rasheed, I've got on the left-hand side of my screen. Can't help myself from greeting you, Fawzia. Lovely to see you. But also other people who are working on the health aspects and the equity aspects of COVID-19. Please don't hesitate to just stop me, as they say. And a special greeting, I just saw Iman Ahmed is here. You might remember that Iman has been working in Gaziantep for the World Health Organization. She's now, I don't know where you are, Iman, I can see you somewhere.
Back in Canada now.
Now in Canada. Lovely to see you again. So yes, as Florence said, COVID-19 is most definitely in the news again after being out of the news for some months. And my objective in having this session with you is to seek your advice on how to help different groups of people make sense of where they stand with regard to COVID-19. That's my exam question. And it's rather deliberately set out like I have, how to help different groups of people, because I don't think every group of people everywhere has the same sense making. In fact, I believe that there's a remarkable variety in how different groups make sense of what's happening. And I'm also saying how to help them make sense of where they stand with regard to COVID-19, as opposed to where we, expressing some sort of generic sense of the people who are in the know, where we stand. I'm interested in where they stand. And this is part of my effort to apply systems leadership, and particularly living systems leadership, to work on COVID-19, because some of you will remember in our description of what it takes to do effective living systems leadership, John Atkinson and I came out with 5 ideas. And one of those ideas was the importance of meeting people where they really are, rather than where we want them to be. And that's why I'm saying different groups of people making sense of where they stand with regard to COVID-19, because we need collectively to find some way of meeting different groups of people actually where they are. And there are some big differences in how different people are making sense of this. And Gregory Hartl in particular has been helping me get access to some of the analyses of different ways of thinking about COVID that exist around the world and in different countries right now. And it's no use, unfortunately, for me just to be saying there are people who are in the right and people who are in the wrong, because that's not going to help anybody. Instead, I've got to be able to find some way of saying there are people who have this kind of pattern of thinking about it, which might be a biomedical one, and there are people who, on the other hand, feel that everything that's been talked about COVID-19 is all a falsehood and it's part of a fairly unpleasant conspiracy to do bad things to people. And that's a real, and in some countries and places, a growing tendency. And so in my effort to help different groups of people make sense of it, I need also to be understanding that they are themselves, even inside their families or in their social places or in their sports places or in their educational centers, they're encountering this big mix of perceptions on what's actually happening. So I'll offer my perception, and I'll offer what I think is emerging as a series of consensus areas, but I'll also do my best to try to identify some of the areas where there is really quite substantial divergence on all this. Now, the general trend that we'd been talking about in these sessions recently was that over time, we expected the virus to continue evolving, and evolving in ways that make it more transmissible, but at the same time, less lethal. And that gradually over the years, we would expect, therefore, to see an evolutionary pattern where COVID-19 and the virus causing it, this SARS virus, would actually calm down, and that there would be less dramatic surges, and that for many people, getting sick with COVID would be a trivial illness. And as a generic and basic statement of evolutionary biology, I think that's probably just about right. And nothing that's happening at the moment suggests that that's incorrect. But if you're in the age range, for example, of 75 to 100 years, you will know that your susceptibility to this virus in terms of getting ill and your risk of getting severely ill and dying is an awful lot greater than if you're in the age range 50 to 75, and much greater still than if you're in the age range 25 to 50. Quite simply, the risks are very much greater the older you get. And again, as we've said before, but I think it's coming out more and more now, the older you are, the quicker your immunity to this virus disappears over time. And the more likely you are to get repeat infections with COVID in succession. Again, the older you are, the more likely it is to be serious. The older you are, the more likely it is to affect you repeatedly. You can reduce the risk of severe illness, and you can reduce the risk of regular infection through getting yourself immunized. And although some of the new variants of the virus that are emerging are able to bypass the vaccine and still cause illness, the vaccines really do reduce the risk of severe illness and death. And it seems they also reduce the risk that comes to about 1 in 20 people of getting long COVID, that kind of COVID that just sticks around for ages and messes up your life. So being vaccinated is a pretty sensible thing to do if you can access the vaccine. And of course, there will be comments about which vaccine is the best one to use. But in general, we're saying getting one of the effective vaccines and keeping your vaccination up to date, getting boosted if you can access a booster, seems to be a pretty sensible thing to do. If you're somebody who seems to react really badly to COVID, let's say you've got deficiencies in your immune response because you are immunodeficient, as they say, or you've actually had to suppress your immune system because you've had a transplant, or you're under treatment for cancer, and that's causing a cutback in your immune system, then it's pretty likely that you are going to be at greater risk. And that means that if you are immunocompromised or immunodeficient or on cancer treatment or in any other way particularly susceptible, as the virus does start moving around in the community in increased amounts, so it does make sense for you to be being careful, and that means avoiding crowds, and that means doing your absolute best not to get coughed on by other people, and it may mean wearing a mask. And those of us who travel, go through railway stations or even crowded airports and so on, we are seeing now quite a number of people who are masked, and I ask them sometimes, why are you wearing a mask? And they'll say back, well, actually, I don't have a very strong immune system, or I've got diabetes and I'm worried about this, or I had COVID before and it really set me back and I don't want it again. And that habit of masking really does make a lot of sense. There are 2 variants that are around at the moment. They're both variants of that Omicron version of the virus that we were talking about last year. One of them is called EG5, or has got the nickname Eris, and that's becoming dominant. It's been around since July, and it has really spread quickly. I mean, there are so many variants that have been monitored. There are 60 or so that have been on the list. And when they're being monitored, when they really are becoming dominant, then they become variants of interest. But they only become variants of concern when they are actually leading to greater severity. So Eris is around, and it's a variant of interest designated earlier this month, but it's not a variant of concern because it is not leading to increased sickness or increased death. More recently, there's another variant with a really difficult name, which is called BA286, BA_2.86. People say to me, why on earth are they given these crazy names? I say, well, that's the scientific name. Over time, it'll get called something else. And yes, it's now being called BA2X. And that's picked up and it's being talked about a bit. It was reported in the UK newspapers because it was detected in London, Denmark, and Israel, and more recently in 2 other countries. And that too seems to be very transmissible. But again, so far, it's not associated with more severe illness. So I don't personally find myself getting super worried about the current variant distribution. As I see it, this is what we would expect to be happening. New variants appearing, more transmissible, and not associated with greater disease. But there is something that's actually creating a lot of problems at the moment. Basically, more and more countries, governments, are just saying, we're not going to continue our surveillance, our sequencing, and our reporting of what's happening in terms of coronaviruses in the community. I don't personally fully understand why. I have some hypotheses. I don't think it's because of lack of money. I don't think it's because of lack of understanding of what is good public health. Because when you're in the decline of an illness, it's really important to keep up the surveillance and the sequencing. But it may well be that it's politically a very tricky thing to do for a government, particularly if there's a democracy, because there's an awful lot of people around who really want to say bye-bye to COVID, bye-bye to the restrictions, and time to get on with life. But my position is that if you want to get on with life, given that we are at this slightly unstable situation with variants emerging, it makes incredibly good sense to maintain investment in surveillance, sequencing, and reporting. I'm very glad to see that a number of governments in Europe and a number of states in the US and so on, as well as governments in numerous lower income countries, are actually doing everything they can to maintain surveillance and to keep communicating with their public about what's going on. And if there's not data information on data available on case numbers, producing those lovely graphs that I used to show in these briefings, at least by tracking people in hospital who have got COVID as a diagnosis, or even by tracking COVID virus in wastewater, particularly sewage, we can understand what the distribution is. Because if we maintain collectively surveillance, sequencing, and reporting, it's less likely that if there is suddenly a surge, that there will then be a clumsy or exaggerated response, and that it will be possible to explain and anticipate what's happening and to work on it in the most, I would say, rational way. And what is the most rational way? Well, I've already mentioned that I would like everybody to keep up to date on their vaccines. But what about all those other things that we were doing? The masking, the distancing, the restricting the number of people we meet, even testing and tracing and isolating. Do we find that they've been any use? Do we find that they've been any use? And there's a very interesting report that has just come out recently, actually from the UK Royal Society. And it's titled Examining the Effectiveness of Non-Pharmaceutical Interventions. And this is the executive summary, super short. And quite simply, it says that as a result of a very detailed survey and series of analyses, and it's a meta-analysis, they conclude that the science confirms what Dr. Maria van Kerkhove and her colleagues working with Dr. Tedros at the WHO have said all the way through, which is that it's better to use a full blend of non-pharmaceutical interventions than to rely on one or other alone. So the use of physical distancing combined with masking and combined with cough control, combined with all the other efforts that we did, for example, to be in ventilated spaces, that taken together through observational studies, it looks as though that's the best way. It's a systems response to a systems challenge, and trying everything possible to avoid going linear and putting all our eggs in one basket, but instead to say, we use the methods that we have in the best way we can together. That's going to get us the best results. Now, we should still identify the people who are most at risk and protect them in a fairly specific, and some would say targeted way. We should still remember that there will be some people who are likely to get affected by long COVID, 1 in 20, perhaps even more than that, with long-running symptoms, and those people will have their lives turned upside down. And we've had several people with long COVID join us on these briefings, and they keep in touch with us. And it is really important that we maintain the visibility of long COVID as an issue. We remember that it's not just people who get their COVID severely that are likely to get a long COVID. You can get long COVID with mild. You can get an okay recovery from one COVID, then you get it again, and you can get the long COVID after the second time. That the long COVID can be particularly horrible because you get better and then you start getting dog-tired again. And it's really not well understood. Our friend Paul Garner writes about it a lot and says, it's not a simple thing where you just say it's all in the mind or it's all in the body. No, it's a multiplicity of interacting causes with a variety of consequences, and it must continue to be taken seriously and understood. We do have treatments that are available that work much better now than they used to. And when we started out, Paxlovid in particular, and there's a lot of very, very good work on treatments. But I want to do everything I can through my own work and in connecting with others and in my work with the WHO to just ask everybody to do everything possible to anticipate and act in advance rather than to somehow turn their back on what's happening and then have a sudden, exaggerated, perhaps over-the-top response, because that could well lead to people being asked to stay in place, even being locked down. And all the evidence is that lockdown really does affect poor people, young people, single-parent households, people with mental illness, people with limited emotional resilience, and people who live in isolated areas. It affects them really, really badly. The consequences of really quite long lockdowns, way beyond what the World Health Organization would ever recommend, during the COVID period, for children's education, for the well-being of poor communities, for single-parent households, and for people with mental illness, the consequences have been huge, and we are still learning about them. So I want to say to everybody, do anticipate and prepare rather than try to forget about it and then get to a situation where in 6 months' time, there's a necessity to react and react perhaps in a dramatic and exaggerated way. As Dr. Maria Van Kerkhove has said recently, now is not the time to let our guard down on COVID. An article that was published in Le Temps in French, and it's been actually translated into the English and other languages because it's so clear. So let's be sharp, let's be smart, and let's try this time to be better prepared. Flo, I stop now and just want to see whether any of this was any use. And as you can probably tell everybody, as always, I'm taking advantage of these moments and the fact that you come and join me to do my own sense making. And I'd love to hear reactions and comments. Greetings to Ndirmwa, Malafa for joining us. It's nice to see you, to hear you just now. I expect we won't be able to see you because your internet's not good, but thanks for joining. Over to you, Flo.
Thank you, David, for this informative briefing indeed. Well, colleagues, do not hesitate to raise your hand, manifest your willingness to take the floor. I might call one or two of you to prime the pump of our conversation. I can't help it. Greg Hartl from WHO, if you can, any reaction, any compliments you want to provide?
Yeah, thank you. I was actually trying to raise my hand and I couldn't figure out how to do it in Zoom. So
not to worry, we found you.
Yes. So a couple of things. I mean, one sort of, David covers the bases so well that it's not easy to find anything additional to say, but I do have two things. One, I think in the wake of this latest uptick in cases, it's really been brought home by Eris and by the B dot, et cetera, variants, that it's not over. And I think we are seeing maybe, but it also could be because August and everyone's on holiday, we're not seeing huge amounts of negative social media in this respect. And in fact, I think as David already mentioned, we are seeing governments already, some entities actively recommending masking again. So there is very much the consciousness that it's not over, that this is a variant, like David said, that probably is, it is much more transmissible probably, but not that lethal. One element that is of interest, and I can't remember which two of the variants it is, carries a quite large number of mutations. And I would say that there's probably interest in media and social media in these two variants because of the fact that they can make something out of this story too, that this has so many mutations that we could be in for almost anything. And that means that we are getting more attention to COVID again. And that's a good thing if we can use the attention from COVID again to get out some solid public health messages. And second point, which is not directly related at all, but David knows that when the special envoys were working, when we used to meet weekly with them, I would draft op-eds for some of the envoys. And now I'm working on op-eds for the chairs, the co-chairs, the bureau members for the INB and IHR amendment processes. And it's actually fascinating to listen to people in the most recent iterations of the ones I've done, from the Eastern Mediterranean and from West Africa, who in fact, it's Dr. Samba Sow, who's I'm working with on the West African one. And he's a former envoy with David, who's obviously still a current envoy. But the kind of conditions that they work under and had to deal with during the pandemic are so completely different from what we can do in more developed parts of the world, that I mean, things like, let's say, lockdowns really would never even come into question. I mean, in West Africa, for example, Dr. So was talking about the fact how, because of economic necessity and borders being so porous, and Mali also being landlocked, there was a lot of movement in and out of Mali to neighboring countries. And I think that that kind of, let's say, congelación in Spanish, so I'm losing the English word, of society and its movement is impossible in developed country settings. And one of the big takeaways I also have from EMRO is the lack of resources.
Yeah.
And that most health systems and governments are so severely underfinanced and under-resourced, both in financial and in human terms, that they had no ability to do sometimes quite the full range of epidemiological functions and, let's say, communications functions that would have been primordial first steps or main steps in addressing a pandemic and trying to respond to it. So I think, again, to just emphasize that the pandemic was not one pandemic, it was hundreds of different pandemics. And it makes it all the more complicated trying to respond to it. Over.
Yeah. Thanks.
David, your mic is on. Do you want to react to Greg before we look into the illustration from Maya?
Just, I was really pleased that he was talking about how experiences are very different in places that have less resources. Also, that for poor people, some of the restrictions that might appear relatively minor can be absolutely massive when it comes to their livelihoods. And I just really valued that introduction of a slightly wider canvas for looking at things. I was appreciating that a lot. Interested in the observation that there's not so much negative social media, but I just did see in the commentary, I think it's from Karen Kaplan, that in the US there is some challenging press around the increased hospitalizations associated with COVID in your country. That's all the sort of thoughts that I had, and I'm really delighted, Gregory, that you complimented in the way you did. Now I see your hands up again.
So please come back, Gregory.
Thank you very much. I think that this is interesting what both David and Karen have just said, because one of the biggest issues we have is trying to determine, I mean, we actively monitor, try to pick up and see and analyze any kind of negativity on social media. And it's often quite difficult to know how much any single post or trend percolates down and out. But, you know, this is like, once, I think, David, this stretches back all the way to the very beginning of you and Dr. Brundtland and whatever, that there was a discussion once, I remember, of politicians saying you can't let one press cycle go by without responding. Otherwise, that's the story that sticks. And in this instance also, I think it's so important that we have to try to find means of responding quickly and adequately and effectively to any and all of these negative posts and negative stories. Over.
Very, very interesting. Thank you for this exchange, Gregory Hartl and David Nabarro. I propose to have a look into Maya's illustration. And Maya, if you want to unmute your mic, any reflection to share with us? What stood out? What was surprising? What was fun to draw? Thank you again for being with us today.
Thank you again for having me. Hi. So some things that came out from it was COVID today and how transmissible and less lethal it's become, as well as like the new variants, and how vaccines and boosters help, and how that we still need to anticipate and prepare for future COVID, and it's important that we maintain surveillance, sequencing, and reporting. I really enjoyed drawing the long COVID. It's just the different characters for them. Yeah, thank you.
Thank you. Thank you for making us smile about such serious issues, Maya. That's really great. Let's take other perspectives. Karen Palmer, I've seen you active in the chat. Would you like to share some views? I would like to invite then Jo Nickolls, Dr. Fawzia Rasheed, maybe, and others. Please manifest yourself. Karen.
Salut. Well, it's only that I keep thinking about that we've set this bar of death and hospitalization as the measure of what seems to matter. And yet I think when we are looking at least 20% of people, as David, I think, just reminded us, with who will perhaps develop long COVID. I mean, that is an awful lot of people with long COVID. And yet, nobody's talking about long COVID in the media. We report hospitalization rates, they're very low. People get the false impression that this is not a big deal, and they completely forget about it. I mean, I can't, Ray Duncan's words from all the previous briefings, are still in my head, and her emotion and the intensity of her experience with patients with long COVID. And I just think we don't talk about it enough. And we have convinced people that it only matters if you die or if you're hospitalized, and never mind long COVID. And I think that's such a huge mistake. And it's especially a mistake, I think, for young adults, and messaging to young adults who have their lives ahead of them. And they sort of feel invincible to death or hospitalization, but they certainly know what it feels like to be sick for a period of time. And I think that messaging needs to shift. And as somebody just posted about rapid testing, yes, messaging on how to properly rapid test, the sort of quick swirl around the nose is not working very well these days with these variants. And so, either teaching people how to really swab, throats and cheeks and nose together and really truly test. I mean, my daughter is staying with somebody who's been coughing for 5 days, and she said, well, she tested negative on the first day, so I guess she doesn't have COVID. And I'm like, she needs to test for 3 days, or more, and properly. And so I think the messaging around how to better protect ourselves is just needs to shift, needs to become more subtle, more nuanced, more specific.
Very important. Thank you. Thank you very much, Karen. You took indeed a question from Elaine in the chat. Elaine, any reaction or any follow-up question you want to raise today? Might be that, no.
Hi, yes, thank you. No, that's good afternoon, everyone. That's really helpful to know. I just know of countless anecdotal stories of people saying, I have all these multiple variety of symptoms which could be COVID, and testing negative, and I'm starting to wonder. Of course, there's always that element of are we swabbing properly and correctly and for long enough, and then also over that key period, 2, 3, maybe even 4 days. But then I was starting to wonder, maybe with the changes in the variants and the mutations, perhaps the efficacy of these tests is declining. So it was just really to ask if there was any science on that. But thank you very much for sharing that response. It was a good reminder to us all of how to properly test and to just do our part in passing that information on. Thank you.
Indeed. Thank you. Thank you so much, Elaine. David, we take more comments before we turn back to you. I think Jo Nickolls was ready to share a few words from where you sit. Jo, the floor is yours.
Thank you. And I think just building a little bit on Elaine's comment, I think there's a lot of things that were very available in the past, which are much less available now. And for example, we have a bunch of old tests. I don't know if the fact that they're old means that they don't work particularly well, but there might be there's less information circulating around a lot of these things, especially, I think, in some of the more resource-constrained countries, as Gregor was mentioning earlier. But it isn't just the money, it's also the ease of access to things. If you have to go a very long way to get a test, you probably don't end up getting the test until you are admitted to hospital, by which point you obviously have been exposed to a lot of people. I mean, in Kenya, in June, there were a lot more people who tested positive for COVID once they were in hospital. But there were reports of, well, certainly more people, but also some oxygen shortages and that kind of thing. But probably also partly because the effort to keep things well stocked has tailed off as the concern has tailed off. And there's certainly, I mean, it was interesting to hear about David saying about the masks, because in the airports I've been going through recently, there are not people wearing masks. There are if you find tourists, but there aren't really very many people sort of wearing masks on a regular basis. And again, I think that messaging of getting things out, that's normal and that's part of a whole package that people can self-decide to do is really important. I'll stop there. Thank you.
Thank you, Jo. That resonates indeed. I've not seen many people where I've traveled recently wearing masks either. Thank you very much, Jo. I will give the floor to Dr. Fawzia Rasheed and then Peter Hurst and other colleagues. Please manifest yourself when you want to speak. Dr. Fawzia Rasheed, the floor is yours.
Hi. Thank you, David, once again. Always brilliant to check in here and get a catch up, which saves an enormous amount of time. I just had one reaction. I've been completely out of the loop on this, and it's a reaction to your statement, which is, can fully understand that it's happened without knowing the reasons in terms of political reluctance to continue with some basic measures, including surveillance. I just wonder, and I think it would be equally important to find out where the temperature is with health workers themselves. Are they willing, as easily as they were back then, to stand behind proclamations of seriousness, actions to be taken, precautions, and so on? And the reason I say this is not because I think they're any less convinced about the science, although that could be, but I think the experience of working with untrustworthy politicians who make bad calls and leave them in the middle to face the public, sometimes without the resources for their own work, let alone to protect the public and follow through with the calls to actions. I really think that that might be an important thing to trawl in, as an equal sort of, as a logical and relevant part of planning for a potential next epidemic. Thanks.
Very important issue also. David, you want to react now, or we turn to Peter Hurst first?
I'd like us to keep talking. Thank you, Fawzia, as always, but I love it to keep talking. Thank you.
Okay, but then let's give the floor to Peter. Peter, the floor is yours.
Thank you. Dr. Rasheed has just mentioned the term health workers, and I want to raise the term workers in general, especially workers in the agri-food system, the workers on farms, plantations, food processing plants, who were actually the front line in COVID. And the point was they didn't have a choice whether they wanted to be COVID free or not. They had to go to work to earn money, to keep their jobs and the like. Now, I think it's important we track what's happening at the work level. What is the change in behavior, in company behavior, especially multinationals? What practical advice can we give to workers? For example, I'm working at the minute with Ukraine, with the health and safety, the agricultural industrial workers in Ukraine on health and safety. They want to return to normality. So we set a process in place of helping them improve their health and safety conditions and standards. I would like that to include good advice, good information on COVID. So it's a plea, really. So don't forget the workers, and it's not just the health workers, it's a much broader community, but they were the essential workers who kept us fed during COVID and are keeping us fed now.
This is again a message that resonates very, very strongly here, where at 4SD we work so much with food systems, and the focus on workers being especially at risk resonates. Thank you, Peter. Iman Ahmed, the floor is yours. If your mic.
Yes, hi.
Yes, here you go.
So my funny list today, I would like to share that I'm doing urban farming, and I would like to show you a little bit of our farm here. Okay, back
Iman.
With the talk. Is that it's the region with the utmost humanitarian emergencies.
Keep going. It was just you were cracking a bit. Turn off your video. We've seen your garden. Beautiful. Go ahead, Iman.
Yeah, the EMRO is the region with a high number of humanitarian emergencies, and that further complicates the issues, where people are looking at very basic health service questions, and then they have to face a return of COVID-19. To echo that point, because in Canada, many, almost the majority of, and even sick days and everything like that have been granted to workers have been rolled out by the governments, and there have been fights over even the compensation in wages, right to sick leave, and all of these things, and there are continuous battles. So if the frontline workers have to face this again, then we are back to square one. And another point I wish to mention is actually a question that I wish to share with you, of whether, because I'm noticing that we are only looking at COVID, and this mostly applies to the pharma companies and the industries involved in responding to COVID. The question is always whether it is going to become endemic, or is it still like a sporadic, is it an epidemic? So is it only through that duality that we have to look at COVID? In my opinion, it's more complex than saying it has now become endemic and then we just sleep on it.
Thank you, Iman. You cut off a bit, but I think we got your core message and your big question. We will turn to the doctors to share their perspectives. For now, I would like to give the floor to Annie Feltham. Annie?
Thanks, and welcome everybody. Mine is quite a simple point, really, although it probably has quite profound implications. And that listening to you all from different countries, but certainly from where I sit, is that COVID isn't an outlier. The way we treat COVID is reflected in the way we treat a whole lot of other areas of government and personal responsibility, and how it's shared or how it's not shared across the system. And that's certainly the experience here, that it sits alongside a whole bunch of other problems that we may or may not be looking at, and the sense in which it was special unto itself, I think has gone, and it's now in the general morass, and in that sense it's not an outlier of all the other things that we're thinking about.
Feels like this, at least, listening to the news in my own country, Annie. Yes, thank you so much. Any other reaction, perspectives, questions for today? Well, David, your reactions to what you just heard from the little round we had.
Thank you, everybody. Really good. And when Iman said, it's such a pity that we seem to have to work with a duality. Either it's a big, serious emergency of epidemic and pandemic proportions, or it's settling down and it's part of the normal ecosystem in which we find ourselves. And she said there's something in between that, isn't there? And I've actually been saying that we're in the in-between phase, and we don't know how long it's going to last for. I don't. But it could be quite a lot of years where there will be what I call the bumpy road, and that bumpiness will manifest itself in different ways. We won't quite know what's going to come. So, yes, I think that being wise about this and anticipating that there will be these moments when new variants appear, or when access to vaccines gets limited, or when even there's a sudden surge, not just hospitalizations, but noticeable increase in severe illness and death or long COVID, that kind of phenomenon is inevitable. And I think that what I can do and what I'd like to encourage you to do is just simply to say that we collectively need to anticipate that bumpy period is around. And that means keeping talking, keeping exploring, keeping learning, because it's only through that we're able to work together and find the best way to move forward. For example, there will be big variations in the coming weeks and months in the extent to which health workers in hospitals will themselves be wearing masks, be asking their patients to mask, will be testing for COVID and more. There'll be big variations in whether health workers and other workers decide that they wish to isolate when they've got COVID, especially if they feel that they're likely to endanger their employment or their income as a result of isolation. And these variations will come because policies will not be stable. There will be a lot of variation in policies. Some of that will be because of different perceptions and experience of policymakers, but some of it may also be because of the particular political direction of the policy-making process. And I think it's inevitable. And I think that folk like myself need to be able to say to each other that working in what is a very confusing environment is going to be the reality. Working in an environment where there's limited standardization of processes and practices is the reality. And we all need to be able to do it without getting frustrated and worked up about it. And for that, I want to encourage dialogue everywhere. If we talk about it, it's much easier to deal with an issue than if we sweep it under the carpet and avoid talking about it. Now, the difficulty with these issues where there is not much conversation about what's going on is that in general, the people who have opportunity, access, resources, power will be best able to navigate to their advantage. The people who have limited ability to realize their rights, limited opportunity, limited resources, real challenges with job security and the like, they just have to do what they're told to. And I think Annie Feltham's point that expecting poor people to take responsibility in the way that is sometimes described can actually put them in a really very difficult situation if they don't have the power with which to exercise that responsibility to the full. So I hold on to what Annie was saying quite carefully. And in the same breath, I hold on to what Peter Hurst was saying, that we are talking about often workers who do not have much agency and who are therefore not able to make choices as they may wish to. And at the same time, they're the people on whom society is particularly dependent. Gregory recently showed me a study which indicated the very high risk that public transport workers faced, particularly in the early months of COVID, that's 2020 to 2021. And the analysis is that they just did not have the wherewithal at the beginning with which to protect themselves. And when some of them asked to be able to protect themselves more satisfactorily, their loyalty to their employers was questioned and so on. So thank you for that point. I think when listening to Fawzia, she was saying that she's wondering about this issue of health workers sometimes having to function in ways that I think what Fawzia was implying was compensates for some of the policy decisions that are taken that are perhaps not working fully in their interests. And I'm not quite sure myself how I want to deal with this, but I would agree that it is really unfortunate that there are often groups in society who are exposed to higher risks because those in positions of authority have not fully taken account of those risks when they're making policy decisions. I mean, it is part of the, in a way, the new culture of public health that becomes so important. That public health really is about enabling everybody to have the opportunities that they need to be able to protect their health as they choose to do so. And that notion that public health is about empowering people to have the best chance to deal with different forms of threat and adversity is so important and needs to be advanced with very careful unpicking sometimes from what is required by different ideological positioning. I don't have the answer, but I know that all of us who work in public health are having to find the way to do this and to do it in a way that enables us to keep working rather than making it almost impossible so to do, because we're probably more effective if we can maintain our roles than if we feel we have to leave them. I'm very pleased to hear Karen talking explicitly about long COVID, and I'm super pleased that in our group we continue to do so. It's delightful to read from Paul Garner that he continues to work in this area with the characteristic care that he does, and I'm very pleased that David Fedson is here and that he continues to work on some of the cell biology aspects of the different kinds of viral infection that's associated with these and other conditions. Thank you to Gregory for being with us. Florence, thank you so much for giving me the chance to make comments on all these. And I think I stop now. And I'm very grateful to Maya for beautiful illustration, to Twee for setting us up.
Well, thank you to you, David, for briefing us as usual. And while you were speaking, there were very important and interesting comments in the chat, some especially on the equity dimension. I know it's dear to your heart, David, emphasized by Stanley from Bolivia, but also Denise in Nicaragua. That's echoing a bit what Jo was saying at the beginning of our round, I just wanted to emphasize this point on equity. But thank you all for your participation, your engagement in this session. Big thanks to Maya for your illustration. For our next session, please keep an eye out to our next newsletter. We're just back from leave and we did not organize ourselves yet on when we will reconvene for a next open online briefing, but you will receive the newsletter and there will be follow-ups for sure. Thank you all. Wishing you a very good rest of the day, nice weekend. Take care, mask if necessary, and convey the right messages. Bye-bye for now.